Beyond the Stethoscope. See it on the Plain Speak Health YouTube channel or listen to the podcasts on Spotify and Apple Podcasts.
Have you ever left an appointment with your healthcare provider wondering, why did they ask me all of those strange questions? Or maybe you've thought, why are they ordering another test? Don't they already know what's wrong? The answer may surprise you. Most people imagine medicine as recognizing patterns. You have a symptom, the doctor knows the diagnosis, and treatment begins. In reality, that's rarely how it works. Medicine is less like solving a crossword puzzle and more like being a detective at the scene of a mystery. Every clue matters. Some clues are helpful, others are distractions. And the first explanation that comes to mind isn't always the correct one. Today, I'd like to let you inside the mind of a clinician. Imagine it's 3 o'clock in the morning. I'm working a night shift in the hospital when the emergency department calls. 62-year-old man, chest pain. That's all I know. Now, here's what many people think happens. The doctor hears chest pain and immediately thinks, heart attack. But that's not how experienced clinicians think. Instead, we begin asking ourselves one question. What are the dangerous things that could be causing this? A heart attack is certainly on the list, but so are a blood clot in the lungs, a tear in the body's main artery, a collapsed lung, severe pneumonia, inflammation around the heart, bleeding ulcers, and even infections. At the same time, there are many less dangerous possibilities, such as acid reflux, a pulled muscle, inflammation of the cartilage between the ribs, anxiety, gallbladder disease. So before we decide what it is, we first decide what it absolutely cannot be. That's an important difference. The goal isn't to guess correctly. The goal is to safely eliminate the conditions that could seriously harm the patient if we miss them. That's why the questions sometimes seem unrelated. Does the pain travel to your jaw? Does it move into your back? Did it begin suddenly or gradually? Does it hurt when you breathe? Have you been on a long airplane flight recently? Have you had a fever? Each answer quietly moves certain diagnoses higher on the list and pushes others lower. Then comes the physical examination, your blood pressure, heart rate, oxygen level, listening to your heart and lungs, pressing on your chest, looking for swelling in your legs. None of these pieces alone provides the answer, but together they begin telling a story. Only then do we decide which tests are actually useful. Many people believe doctors order every available test just to be safe. In reality, every test has strengths and limitations. A normal blood test doesn't rule out every heart attack. An X-ray can't see every blood clot. Even a CT scan has situations where it may not give us the answer. Tests don't replace thinking, they support it. One of my favorite sayings in medicine is this: never order a test unless you know how the result will change what you do next. Good clinicians don't collect tests, they collect evidence. As new information arrives, our thinking changes. Maybe the first blood test is normal. Good news, but that doesn't always mean we're finished. Some heart attacks don't show up immediately. That's why we repeat certain blood tests hours later. To patients, that can feel frustrating. To us, it's simply good medicine. We're watching the story unfold instead of assuming we already know the ending. Here's something else that surprises many people. Clinicians don't spend most of their time trying to prove themselves right. We spend a tremendous amount of time trying to prove ourselves wrong. If I think it's acid reflux, I immediately ask myself, what if I'm wrong? What finding would change my mind? What diagnosis am I overlooking? That's one of the habits experience teaches. Confidence isn't believing you're always right. Confidence is being willing to reconsider when new evidence appears. Medicine is full of uncertainty. Patients sometimes expect certainty. Television certainly makes it look that way. But real medicine is different. Good clinicians become comfortable making decisions even when every answer isn't available yet. We gather information. We estimate risk. We rule out the dangerous possibilities. We adjust our thinking as new information arrives. It's a process, not a magic trick. So the next time your clinician asks what seems like an odd question or orders a test you weren't expecting, remember this: they're not just treating a symptom, they're solving a puzzle. Every answer you give becomes another piece. Every test adds another clue, and every decision is built on hundreds of small observations that most people never see. That's what happens behind the stethoscope. If you enjoyed today's episode and want to better understand how healthcare really works, I'd love to have you join us each week. Please take a moment to like this episode, subscribe to the channel, and share it with someone who would enjoy pulling back the curtain on medicine. Every week, we'll translate the language of healthcare into plain English so you can become a more informed patient, caregiver, or healthcare professional. And if you'd like to read more stories from life on the night shift, my new book, Nights Like These, What the Night Shift Teaches You About Medicine and Yourself, is available now on Amazon in both paperback and Kindle ebook editions. And for free resources, visit ps-health.com, where you'll find our free hospital survival toolkit, an easy-to-understand medication guide, resources designed to help you navigate healthcare with more confidence. I'm Arn Facklam, nurse practitioner, fellow of hospital medicine, and host of Beyond the Stethoscope. Thanks for spending a few minutes with me today. Until next time, stay curious, ask questions, and remember, the more you understand what's happening behind the stethoscope, the more confident you'll be in front of it.